So, what is gestational diabetes? Gestational diabetes, or GDM, is a condition characterized by high blood sugar that develops during pregnancy and generally resolves after birth. The reason why it's so important to identify gestational diabetes is to give you meaningful information, to make diet and lifestyle changes, and monitor your blood sugar to make sure that your blood sugar is within normal range. Many people believe that gestational diabetes is a high-risk condition and it puts you in a high-risk category. But the truth is that gestational diabetes comes with risks, but with diet controlled, those risks are still very low, and many people can control gestational diabetes with their diet. I've supported dozens of home births or birth center births with moms who had diet-controlled gestational diabetes. And in more rare cases, if gestational diabetes can't be controlled with diet, a combination of diet, lifestyle, and medication may be needed. That often will risk someone out of an out-of-hospital birth, but it's important to acknowledge that you can still have a great birth even if you do have gestational diabetes, especially if you're wanting a low-intervention, unmedicated birth. That is absolutely possible with gestational diabetes. It's just important that you learn how to navigate the medical system. If we're in a category that comes with more risks or providers are considering us to be in more risk, or there's provider bias, maybe big baby bias, which can come with gestational diabetes, we need more preparation and education around how we're going to navigate that system of care to support you in having a lower intervention birth if that's what you want to have. Someone with gestational diabetes is potentially more likely to experience a shorter trial of labor or increased likelihood for C-section or induction due to big baby bias. So creating a plan around where we're going to incorporate evidence-based strategies to reduce your risk and navigate those gaps in evidence is absolutely essential when planning to navigate the medical system rather than just going in, learning about advocacy, and then hoping for the best. We want to be deliberate. Let's talk about when testing happens and the options that you have for testing. So testing for gestational diabetes typically happens around 24 to 28 weeks. However, if there are risk factors or early concerns, testing can happen at the very beginning of pregnancy, getting an A1C blood draw. An A1C might not indicate if you develop gestational diabetes, nor in many cases does it replace testing later, but if you're curious to see what your blood sugar is doing and if you're developing any kind of insulin resistance in pregnancy, getting an A1C, which is to look for insulin resistance, might be helpful. Because a lot of moms say that they do have risk factors for gestational diabetes, and then they find out later in pregnancy in the third trimester that they have it, and they're so disappointed that this entire time they could have been working on their diet if they were given some meaningful information beforehand. When it comes to testing, you have options, and there are many options. So option one would be that early A1C testing that I mentioned. This measures your average blood sugar over the previous 2 to 3 months, and it identifies pre-existing blood sugar issues early before GDM typically develops. Option two is the main option, and this is the standard glucose test. So the glucose screening approach varies depending on where you live. In the United States, care providers typically use a two-step approach. Step one is the 1 hour glucose challenge test. So you're basically going to drink a drink with 50 grams of glucose without fasting, usually without fasting for a long time. Typically fasting is recommended for a few hours beforehand. I encourage you to eat a protein-rich breakfast that day. And then blood is drawn 1 hour later after you drink the drink. If the levels are elevated, then you move to step two, which is the 3-hour oral glucose tolerance test. For this, you have to fast, consume the drink with 100 grams of glucose, and have blood drawn several times with fasting at 1 hour, 2 hour, and 3 hours. You need to have 2 elevated readings to be diagnosed with GDM. Internationally, and as recommended by the World Health Organization, there are many countries using a one-step approach. So this involves fasting, consuming a drink with 75 grams of glucose, and having a blood sugar draw while fasting at 1 hour and at 2 hours. In this model, a single elevated reading results in a GDM diagnosis. Regarding the research on the standard test, Evidence-Based Birth notes that the standard glucose beverage is highly standardized for accurate results, but it can cause side effects such as nausea, vomiting, dizziness, and headaches. So if you vomit during the test, the results are invalidated and the test must be repeated or an alternative method used. The glucose drink that you get is usually from the lab. The flavors that I'm aware of are orange and lemon lime. Maybe they're different in other places. And that lab drink does have artificial ingredients. Option three is the fresh test. If you want an alternative to the standard glucola drink, there's an option called the fresh test, and many labs are accepting the fresh test as an adequate form of testing. This is a commercially available beverage formulated with clean ingredients like organic lemon and mint, and it delivers the exact 50 gram, 75 gram, or 100 gram glucose load required for accurate screening, meaning it fills the clinical requirements for the test without all the artificial additives. A lot of people are told that they could just eat like a whole bunch of jelly beans, or they could drink a smoothie with 50 grams of glucose and that could work. But that isn't true. Other components to the candy or to the smoothie can mess with the test results. Another option would be to finger prick and food log. So if you don't want to drink 50 grams of glucose and get a blood test, maybe this is a good alternative. So with this test, you can monitor your blood sugar at home for at least 2 weeks. This involves using a standard glucometer to prick your finger and test your fasting blood sugar, as well as 1 to 2 hours after meals. So you take your blood sugar in the morning, and then 2 hours after your meals, you take your blood sugar again. This can give you meaningful information around how your body processes your standard daily diet, and I think this is a really great way to get to know yourself and your body better. For daily monitoring, the recommended targets are about 95 for your fasting. For 1 hour after a meal, it's 140, and for 2 hours after a meal, it's 120. So you could log everything that you eat, and you can prick your finger every single day, 3 times a day after meals, 2 hours after meals, aiming for 120 or below, and fasting, meaning when you wake up in the morning, aiming for 95 and below. If you notice your fasting is really high, perhaps we need to incorporate more protein snacks before you go to bed or in the middle of the night when you get up to pee. If your daily numbers are high, maybe we need to incorporate more protein and fiber and less sugar. You might notice that potatoes spike your blood sugar, or a pepper spikes your blood sugar. So it's about learning yourself and your body and what foods cause your blood sugar to spike. Bring this log to your provider. Option 5 would be to get a continuous glucose monitor, or a CGM. So for deeper insight into your blood sugar, continuous glucose monitors are wearable sensors that track blood sugar in real time. So instead of relying on isolated finger pricks, the CGM provides continuous data and a curve. And this shows the exact blood sugar peaks and reveals how specific meals or stress or activity levels affect your numbers. So if you don't like pricking your finger very much and you want to just put something on your arm and wear it for 2 weeks and see what the blood sugar levels are, maybe you could try that instead. But it's still important to log everything that you eat so you learn over time how your blood sugar is impacted by what you eat. Understanding blood sugar is really helpful because managing GDM centers on stabilizing blood sugar spikes. Your blood sugar, when it spikes, releases insulin, and insulin is a growth hormone. When your blood sugar spikes, baby's blood sugar spikes too, and then baby's body releases more insulin. If baby's body is releasing more insulin, that might cause baby to grow a little bigger, which is why keeping your blood sugar in normal range is important. Is your baby going to grow too big for your body to birth if you have diet-controlled gestational diabetes, meaning throughout your pregnancy you have the monitors or you're pricking your finger consistently, making sure that everything you eat is keeping your blood sugar within the normal range? Probably not. There's a lot of fear that if I have gestational diabetes, no matter what, my baby's going to get too big and they're not going to fit, and there's all this fear and this concern. And yes, gestational diabetes does come with some risk, but when well managed, your blood sugar might be better than the mom next door who isn't managing her blood sugar. And I've personally attended many births with moms who have diet-controlled gestational diabetes and their babies were very small. So gestational diabetes is not something to be afraid of. I want you to feel empowered to make choices, to get to know your body and your diet and your lifestyle to support your health and your baby's health, but not to stress or be afraid and freak out about it. So some ways to support blood sugar would be to avoid long fasting periods, so eating a snack before bed, eating a snack not too long after waking up, eating lots of fibrous vegetables because the fiber helps stabilize blood sugar, and eating lots of protein. Aim for at least 60 grams of protein a day. If you could do more, that would be great. You could log everything that you eat and run it by a nutritionist, or you could run it through AI and ask, how much protein am I getting every day? Also, movement can help stabilize blood sugar. So going on a walk for 10 to 15 minutes immediately after meals helps to manage your blood sugar, because this helps your muscles absorb the glucose rather than putting it into your bloodstream. So when looking at the effects of blood sugar in pregnancy, the HAPO study from 2008 demonstrated that the relationship between maternal blood sugar and poor birth outcomes is continuous. What they found is that the risk for adverse outcomes increases step by step with every small increase in blood sugar levels. Studies by Hippo in 2008, England et al. In 2009, Tobias et al. In 2017, Clausen et al. In 2009 link high blood sugar in pregnancy to higher rates of preeclampsia, fetal high blood sugar, first-time cesarean birth, and premature births. It's also linked to a higher birth weight, shoulder dystocia when the shoulders get stuck, newborn intensive care admission, newborn jaundice, and newborn low blood sugar. Babies are more likely to have low blood sugar after they're born because they're used to having higher blood sugar and releasing insulin to compensate for the high blood sugar. When baby is born, they're not getting that big sugar dump, but they're still releasing the insulin, which can make their blood sugar drop. This can sometimes cause some challenges with initial feeding, and it can be dangerous if not managed properly. Long term, it increases the future risk of diabetes and heart disease for the mom and excess body weight or diabetes for the baby. An effective treatment of high blood sugar brings the risk of these health problems down. So in some cases, effective management returns the risk to the baseline of someone without GDM. Also, I want to discuss fat phobia and how that plays a role in gestational diabetes. So when looking closely at the research on gestational diabetes, we see how a patient's size and the suspected size of their baby heavily influences the care that they receive. So the evidence-based birth article on gestational diabetes highlights that in observational studies, the people who are placed in the induction group tend to be those with higher BMIs, and we know that BMI is highly flawed. This means that the data is often skewed from the very beginning. People with higher BMIs are frequently pushed towards earlier medical interventions, creating situations where we're comparing and already heavily medicalizing a group against those who were allowed to wait for spontaneous labor. So this hyper-focus on size extends directly to the baby through the medicalized fear of macrosomia. So with GDM, care providers often use growth ultrasounds in the third trimester to identify the baby's weight. Despite the fact that these estimates are notoriously inaccurate, you could be told that your baby is suspected to be big, experience all of the bias that comes with a suspected big baby, and then it turns out your baby is not big. So it's incredibly common for providers to suggest an induction before 40 weeks or even a cesarean to prevent the baby from going too large. But evidence-based birth notes that the evidence does not support induction for big babies. Even ACOG, the American College of Obstetricians and Gynecologists, acknowledge that there's insufficient data to prove that scheduling a C-section for a suspected big baby is actually going to reduce negative outcomes. So in practice, clinical terms like macrosomia are frequently used to justify interventions that the evidence simply does not support. So a primary focus for care providers managing GDM is macrosomia, defined as the baby weighing at least 4,000 grams or 8 pounds, 13 ounces. The global rate for babies weighing over 4,000 grams is 8 to 9%, and this rate can exceed 15% for those with diabetes in pregnancy, according to a study by Salihu et al. In 2020 and KC et al. In 2015. Effective blood sugar treatment reduces this risk to normal levels, found in a study by Akanmode and Mandy in 2025. So well-controlled gestational diabetes with diet is not something to be really afraid of, just something to be aware of. It is true that a higher birth weight increases the risk for shoulder dystocia, which is a complications where baby's shoulders catches on the pubic bone. And if not managed quickly by a healthcare team, it can cause a brachial plexus injury, which is the nerve injury to the shoulder and the arm. And this is the leading cause of obstetric lawsuits. So acknowledging that obstetrics is a highly sued profession and many obstetricians practice defensive medicine and have liability woven into their medical decision making, it's understandable that they might operate in fear and you might experience that fear of baby getting big. But that is not your fear to carry, that is their fear and their projection of fear onto you. It's important that you make an individualized decision when considering if your baby is big or not, which unfortunately we cannot know until after your baby is born. We just can't. And if you want to stay pregnant or if you want to induce or do more testing. But research by Youfaced et al. In 2023 and Albed Wahab et al. In 2023 indicates that GDM does increase the risk for shoulder dystocia even if the baby is not classified as large, because high blood sugar may impact fetal weight distribution, leading to broader shoulders, compared to the head size. If a large baby is suspected, care providers may recommend an induction before 40 weeks or scheduled cesarean if the estimated weight is over 4,500 grams. When looking at how often induction is used for GDM, data indicates that the practice is frequent and increasing globally. So in Australia, inductions for pregnancy diabetes rose from 8.5% of all inductions in 2012 to 15.3% in 2020. And that is from a study by Aziz et al. In 2025. In Ireland, 21% of inductions in 2022 were based on maternal health indication, which includes GDM, from a study by Nicholson et al. In 2024. In Sweden, a population-based study found 21.2% of people with GDM were induced compared to 10% of people without GDM, from a study by Navander et al. In 2023. In Austria, approximately 40% of people with pregnancy diabetes were induced, primarily those requiring insulin, from a study by Reicher et al. In 2023. So unfortunately, in the United States, birth certificates track inductions poorly. A linked data study reviewing 330,000 births from 2021 to 2007 found an overall induction rate of about 30%, with diabetes accounting for 10% of the medically indicated inductions. And that's from a study by Dublin et al. In 2024. When comparing outcomes between induction and expected management, most research relies on observational studies. And these studies have limitations because the induced groups often have higher risk profiles. Those with inductions are more likely to be older, have higher BMI, require insulin, and have hypertension or preeclampsia. So the available evidence that we have shows that if the baby is born before 39 weeks and 0 days, or after 41 weeks and 0 days, there are increased risks. So birthing your baby between 39 and 41 weeks in that window is kind of the sweet spot. Most studies show no difference in cesarean rates between inductions and expected management between 37 and 39 weeks, but one study found a lower rate with 38 or 39 week inductions, while another found higher odds of cesarean with inductions at 38 weeks and beyond. And that's from Simon et al. In 2022. So risk is also influenced by the Bishop score, which is a score to identify how prepped your body is for birth. So if your baby is low, your cervix is soft and opening, and it's showing signs that your body is ready to go into labor soon, the induction is more likely to be successful. It's more likely to have a failed induction leading to a cesarean if you have a low Bishop score, or it's confirmed that the cervix is long and closed, baby is up high, and your body isn't really showing signs that it's ready to go into birth yet. If you're in my coaching program, you will learn all the options for induction and how to prepare your body for induction. The problem with inductions is that we're told you have to get an induction, and then we go in and we get the induction, and there isn't any preparation around creating space in the musculature around the pelvis to support baby in being in a good position, how to get baby to engage well, how to support your cervix in changing and opening, and how to prepare your body in all these other ways physically in the days or weeks beforehand to make the induction more likely to work. This is something that you will learn and get personalized support with in my coaching program. Click the link below to join my free Peaceful Birth Academy to get started. Also, there are no recorded differences in maternal mortality, severe maternal morbidity, or ICU admissions for the mom when it comes to inducing. So let's talk about the impact of inductions for moms. If you choose to get an induction, it can make your birth a more medicalized experience. You can have a great induction experience. You can definitely use lower risk tools, and often inductions can make birth be a more medical event. It's more likely to get Pitocin. It's more likely to get an epidural because inductions can make labors longer and more painful. So it's important to acknowledge that that is an increased risk if you choose to induce, and this might be important for someone to consider if they're wanting to have an unmedicated birth. There is a risk of a failed induction leading to a cesarean. You'll likely have a longer hospital stay, but if you're at home or birthing at the birth center, you may induce with castor oil or with other natural tools, which come with less risk but still can increase the likelihood of birth being more painful or contractions being closer together, often due to the castor oil. There are no differences recorded when it comes to induction for maternal morbidity, severe maternal mortality, or ICU admission. And that's from a study by Metcalf et al. In 2020 and Lowe et al. 2023. Regarding outcomes for the baby, induction lowers the risk of having a baby over 4,000 grams, but it does not change the rate of a large for gestational age baby. Most studies show no difference in shoulder dystocia rates between the induction group or the expectant management group waiting for spontaneous labor. Inductions prior to 39 weeks are associated with higher rates of infant health issues, including NICU admission, jaundice, and hypoglycemia or low blood sugar. The absolute risk of perinatal death is very low in both groups. Robinstein et al. In 2012 found a lower risk of perinatal death for births between 39 weeks and 40 weeks compared to expectant management, meaning waiting for spontaneous labor. They noted that 1,300 to 1,500 people with GDM would need to be induced to prevent one perinatal death. Other studies found no difference in perinatal death. Due to the lack of randomized controlled trials, guidelines vary by region. So in the United States, ACOG states from 2018, for blood sugar controlled by diet and exercise known as A1 GDM, expectant management is appropriate up to 40 weeks and 6 days. For those requiring medication, known as A2 GDM, birth is recommended between 39 weeks, 0 days, and 39 weeks, 6 days. In the United Kingdom, NICE 2017 and 2020 guidelines recommend that care providers offer induction or cesarean if birth has not occurred by 40 weeks and 6 days. In Canada, induction is generally offered between 38 weeks and 40 weeks. The Perinatal Services of British Columbia 2025 updates recommended treating diet-controlled GDM like standard pregnancies, recommended treating diet-controlled GDM just like a standard pregnancy, and recommending induction at 39 weeks for medication-controlled GDM, and 38 weeks if blood sugar is not at the target levels. So in summary, gestational diabetes is a condition that some people can develop in pregnancy. That means that there's some level of insulin resistance that has reached a threshold where risks can start to become present for a baby. There are many different options for testing, some in the beginning of pregnancy and some later in pregnancy around the 3rd trimester. If you have gestational diabetes and you can control it with your diet and lifestyle changes, the risks that come with gestational diabetes decrease significantly. Many organizations around the world recommend inducing for gestational diabetes between 39 weeks and 40 weeks and 6 days. And the research does indicate that the window for birth that is most ideal with someone with gestational diabetes is between 39 weeks and 40 weeks and 6 days. At the end of the day, you have self-agency. You have the right to choose. Do you want to do an induction? Do you want to wait? If you want to induce, do you want to do natural tools, mechanical tools, or medical tools? You also have the right to choose what kind of testing you want to do for gestational diabetes. If you want to do the finger pricks, the fresh test, the continuous monitor, or the glucose drink. Talk to your provider about the options. My private coaching clients achieve outcomes 9 times better than the national average, and that's because they followed my 5-step foundational framework I created called the Peaceful Birth Method to support you in having a peaceful birth. Click the link below to access the same 5-step framework that they used to get these results. You've got this.